A very good morning, ladies and gentlemen, and a very warm welcome on the 9th day of the biggest virtual implantology event of 2020. Yes, ladies and gentlemen, I'm talking about the world's first virtual implant expo organized by your very own dental company, DentistChannel.Online. My name is Ruben Lobo, and it's a pleasure and a privilege and a very warm welcome to each and all of your lovely people who've joined us from various parts of the globe. Ladies and gentlemen, we have with us Dr. Rama Raju. Before I talk about his profile, or rather his bio, I would like to tell you that Dr. Rama Raju is in the near future going to help and save millions of people all across the globe. He's doing a wonderful job in research, and the new product that he has come with, rather, which is already in picture, which is soon going to be a big hit in the Indian market as well as all across the globe. Ladies and gentlemen, Dr. Rama Raju is certainly going to help a lot of people, and he's going to touch a lot of lives with his product. So before I move to his introduction, I would like to thank you, Dr. Rama Raju, for accepting our invitation. And we are so very happy to have you as our keynote speaker on the 9th day of the world's first virtual implant expo. Ladies and gentlemen, a short introduction about Dr. Rama Raju. Dr. Rama is an honorary professor at the SVS Institute of Dental Sciences. Formerly, he was a professor and the head of the department in the same institute. He's a founder of the Curcuma Biosolutions. He's a practitioner at Sri Satya Sai Oral Health Center since the last 20 years. He's a business manager for Journal of Indian Academy of Oral Medicine and Radiology. He's achieved the Young Research Award from the IAOMR for the year 2017. He has about 30 publications in various national and international journals. He's filed a patent on intraoral topical application of curcumin, which has more addition to the oral mucosa for enhanced action of curcumin, which is highly effective in oral submucous fibrosis. This was shown by the drug docking of curcumin and cytochrome 450 SNP, which is responsible for OSMF. Moving ahead, he's filed a patent on the economical oral cancer screening device. Yes, ladies and gentlemen, I was talking about this, something that is going to change and help millions of Indians and all individuals from various parts of the globe. And the same has been filed in Indian, PCT, US, and China. It is also approved for funding by the Department of Science and Technology under the category of commercially viable academic projects, Government of India. It has also been accepted for nomination of BMJ South Asian Awards in the year 2017. He's presently working on identifying SNPs in various mucosal lesions and treating them with a drug, which is identified as having more binding through drug docking, along with natural compounds, which has more binding with the SNPs. Ladies and gentlemen, presenting to you, Dr. Rama Raju live.
Thank you, Mr. Ruben, for your great introduction. Whatever the introduction that has given, that is a part. And basically, I'm a dental practitioner, private practitioner for the past 20 years. And today's topic I've selected as the conundrum between the immediate and delayed loading. And I've used the word conundrum here only to I've used the word conundrum here because it is very much confusing for the practitioners, which is very much confusing for the dentists all around who are practicing implants. What exactly we are doing with this? The implants, what we are doing, because when I started my implant practice, one of my junior, Dr. Lakshman from the All India Institute of Medical Sciences, he taught me the implantology when I started doing implants. But what he said is initially, at that point of time in India particularly, we were all using some kind of implants, which are of course low cost. Even now that is happening. And whenever we are using some kind of implants, the screw loosening and abutment loosening, these are the things we used to happen. It used to happen regularly. But only thing is what he has done, he has told me at that point of time, maybe roughly around 2006 or 7, when he was doing some kind of implants in my clinic. He said the future is going to be single piece implants, where there is no connection and there is no connection failures and everything. But when once I see, even the literature is showing that very good development in even the two-piece implants and even in the single-piece implants. There is nothing like that something is vanished or something is this thing. So before starting my presentation, I would like to pose a few questions, or probably I may answer these questions. I'll try to answer these questions in this my presentation. That is, the first question is, why do we wait for 6 months or 3 months or to low implants in the maxilla and the mandible respectively? Does waiting for one more than a prescribed period improve osseointegration? Is it true or false? What is better, augmenting the site and placing the implants later, or doing both at a time, the same result? And how different is the immediate loading from the delayed loading as far as bone health is concerned? Because the implant is nothing but a mechanic material or the metal into the bone, and we need to consider the metal and we need to consider the bone. So these are the only two things that are more important when we are placing the implant. So we need to understand what exactly the bone, how exactly the bone responds, what is the biology of the bone, what is the mechanobiology between the implant and bone, and these are the things what we need to understand. So before understanding all these things, the word osseointegration, it becomes the most important thing, because osseointegration is the only thing what we need to understand before understanding the implant or before understanding the whatever the science behind this. And this has been developed in over the decades in both laboratory and clinical environment as a result of extensive multidisciplinary cooperation. So to understand the osseointegration, start about the osseointegration, we need to think about this man who has invented or who has coined the term, or who is, we can say, father of the osseointegration or implant, is Dr. Brenmark. So both et al. In 1940 were the first researchers to implant titanium in an alumina and remarked how had the tendency to fuse with the bone. This is what we call as osseointegration. And it was later discovered by the various other scientists. And titanium screws, they fixed the titanium screw in the rat femurs. At the end of 6 weeks, the screws were slightly tighter than when they originally put in. And after 12 weeks, again they checked it. It was much more difficult to remove. And after 16 weeks, when they tried to remove it, they have to fracture the femur of the rat. That's what happened. And these are the images I would like to show you. So this was the experiments, and this is the uh, image of the fractured rat bone where the implant is completely adherent to the uh, bone. So the definition, various definitions were given by various other people and societies and persons and many people. The direct structural and functional connection between the ordered living bone on the surface of the load carrying implants is one thing, what is given by Brenmark, and AI has given something, and everybody has given their own definitions. But this definition I would like to bring to your notice. A few years back, when I've attended a single piece implant course, or the cortical implants or the basal implants, that is a course I've attended. In that, they have mentioned this definition, that is, osseointegration is defined as a close approximation. The word close is important here because they say it's a close approximation of the bone to implant surface. It is not the bonding. Biological process of the bone growth towards endogenous implant surface followed by a build-up mineralization. They say there is no bonding, only adherence. And what is the difference between the bonding and adherence? We have to think here. The adherence is placing a little bit near. The bonding is both are probably fusing. When coming to these terms, whenever we need to think about the modeling or remodeling of the bone, we need to think of bone formation whenever there is some kind of mishap happens, or whenever there is some kind of surgical trauma happens, or some kind of accident happens, or whenever some approximation of the tissues and everything. But when we go into the literature and search into the literature, or when we go think of what is the gap between the two cells in a normal tissue, what is the gap between the two cells of a bone tissue, what is the gap between the cells when they got modeling or remodeling and everything. So the gap between the implant and bone is roughly even 14 nanometers when it is thoroughly fixed or thoroughly osseointegrated. But even when you consider cells or the particularly cancerous bone, or sometimes in other part of the body, the gap between the two cells of the bone is in microns. So 40 nanometers, whether we call it as adhesion, adherence, or whether we call it as bonding, absolutely there is doesn't make any difference what I feel, because if we think of physics and everything, there is no complete realization of any cells, but probably the close approximation what we call as bonding. So this is biology of the osseointegration. What we need to think is uh, understand it. Whenever you do some osteotomy and place an implant, there is hematoma initially in first image, and probably when the healing period, it can become callus. Loading period, it will become border bone. In unsuccessful implants, of course, it is pseudoarthrosis or fibrous integration or fibrous integration or failure of the implant, whatever you call it as. So soft tissue interface will be there, cortical bone is there, spongy bone is there. These are the everything, ultrastructure of the osseointegration, that newly formed bone. So in 1985, Jupiter has observed two ways of implant anchorage, that is mechanical and bioactive. Mechanical, all we know, when we place the implant, it gets very good stability, and that is what is the primary stability, what we call it as. Mechanical anchorage is important for two-piece implants or the conventional implants. What we talk about, we may think of the torque, we measure it, that is maybe 40, 45, whatever it is. And if we go for immediate loading implants, they may say even much higher, that sometimes even they say that 110 is the um, torque that is needed to load the implant. And another anchorage is bioactive. What is this bioactive anchorage? So basically, we need to understand biology and mechanobiology. That is what I'm talking about. That is the bonding between the implant and the bone. That is mechanobiology. So all these factors come into the bone. That is mineralization, cellular remnants, thickness, porosity. It's not a simple structure. It has got a lot of complicated things in this, and we need to understand all these things. And people have done research over the decades to understand all these things, and they've probably placed it that all these things will help to success of the implant. So we have three kinds of bone is, that is bundle bone, woven bone, and lamellar bone. And this lamellar bone is mature cortical trabecular bone, which is very much helpful for us to for this primary stability or for success of implant. Woven bone again, a little bit softer bone compared to the lamellar bone, little bit low mineral content. It lacks the strength to resist the functional bone. So whenever we place the implant in woven bone, probably we cannot load it functionally. I'll explain what exactly the functional load is. Probably for a senior practitioners of implantology, these are all the simple things, but I would like to involve all these things because the biology, reminding about the biology, knowing about the biology is always helps us to be stick to the basics, which is very important for us to not to lose the touch with the advancements. So bundle bone, which is absolutely not useful for this thing, and that bundle bone we learned in our early BDS days that sharpest fibers involving in this. So the cortical and trabecular bone through the body are constantly modified by the modeling or remodeling. This is basically bone physiology. The modeling is independent sites formation and resorption and result in the change of the shape and size of the bone. That is modeling. So here in modeling, the resorption and formation. Initially the formation, then resorption. Probably the bone structure may change, the bone physiology may change. The remodeling is resorption and the formation. Initially the resorption will be there, then probably it will form as a formation. So when it is resorption, probably what we are doing at the time of osteotomy is we remove some kind of the bone with some burr or everything, and then the bone will get remodeled to give our secondary stability for the implant. So the bone remodeling is the important aspect in whenever we are talking about the implants. It is a turnover or internal restructuring of previously existing bone coupled tissue phenomenon. This remodeling cycle will take approximately 17 weeks in humans. This is what is given in after various histological studies. The remodeling include localized changes in individual osteos or trabeculae. This can happen. The turnover, hypertrophy, atrophy, or reorientation is one thing, which is again important bone remodeling. So we all know D1, D2, D3, D4, where we have to place what and what is the kind of the bone in D1, D2, and D3, D4. How to deal with these kinds of bone before starting the placing the implants, and which is contraindicated, and if it is contraindicated, what are the options that we need to think about it. All these things we need to understand. And once we understand about the bone, then again, what is the relationship between the implant structure of the bone and the bone? That is one more important thing. That is, each 1 mm increase in the diameter corresponds to surface area of increase approximately 20 to 30%. So whenever there is a diameter increase of 1 mm, you are placing a 4 mm implant or 5 mm implant, almost 20 to 30% of the diameter will be our surface area. And we all know in the physics, basic physics, that the increased surface area will help in holding the structures in for longer periods, and it improves the structure of the implant what we place. The stress equals the force divided by the functional area. This we know, we have read in school physics and everything. The greater diameter decreases the amount of stress at the crestal bone of implant interface. And most of the implants, with our experience we have seen in all these years, is crestal bone loss is very common whenever we give abnormal prosthesis or a prosthesis which is not exactly uh, suitable for the occlusion. Because early bone loss and complications related to the crestal bone regions the width of implant is much more critical than the height, because the height is also important for us, but the width is more important than the height, because whenever the height of the implant is 3 mm more, the only 10% of the surface area will be increased. But in kind of width, 1 mm increase in the implant surface area will give us almost 30% of the increase in surface area. So the advantage of increased height uh, is whenever we are placing the long implants, whenever we are to engage the cortical bone or the stronger bone, or whenever we, and it is always to go for lengthy implant, because we need to place primary stability or long-term resistance for the movement of forces, everything. The longer implants are very much useful. But some studies say that any implant which is more than 10 millimeters in length or normal or equal. So there is again controversy in the literature, because many people do a lot of studies, and every study is contradicted by another study in coming years. So after understanding the physics of or the structure of the implant, then again the surface characteristics also very important. That is topographic properties, physical properties, physiochemical properties, and these are the things, because a lot of research is going on in this thing. A lot of publications are there, a lot of review articles are there in this thing. The texture, surface texture, roughness, even the rough part of the implant is also helps in osseointegration and everything. So roughness parameter is smooth, minimally rough, moderately rough, and it's rough, which is more important. So the studies has proven that the moderately rough surface is much more helpful for the osseointegration or more bone contact if the implant has to when placed in the implant. Smooth surface, of course, even it will go undergo some kind of osseointegration, but it may take a little bit longer time, or it may take bit uh, lesser osseointegration compared to the moderately rough or rough implants. And another thing is regarding surface coating, nano size hydroxyapatite, increased initial stability, more rapid healing, and everything is supported by documentation. Plasma staying in doping. This is the picking up very fastly. That is, growth factors are incorporated on the surface of the implant, so that they can improvise the bone growth, or they can involve that so-called adherence or bonding in between the implant and the bone. The laser etching of the this thing, and various surface treatments, turn surface, sandblast, acid etch, titanium plasma, and hydroxyapatite coatings, and these are the various things, and everything microscopically explained. What is the difference between the each and every technique to do the surface texture? And this is also an established fact that whenever it is machine turned, only 42% of the bone implant contact area will be established in 3 months. And when you go for the hydroxyapatite, 79% of the bone implant contact area will be established in 1 month. So these are the various parameters and various comparisons which have been done, which are very, very important for us to understand. And we should know that every single aspect which is incorporated in implant, or which is incorporated in a technique, are important for the osseointegration. And whether somebody accepts or not, the osseointegration is definitely a part of implantology practice. And what is bioactive, what is mechanical? So bioactive materials, what we are discussing about plasma straying, hydroxyapatite coating, or any other kind of roughening and everything. Mechanical is, again, we have to talk about the alloys or titanium or various materials that we are using in implantology practice. So why, generally, why only titanium? Why not some other thing? So these are the features of the titanium implant: titanium material, high corrosive resistance, biocompatible material, non-magnetic property. This is, there are three kinds of magnetic properties: ferromagnetic, diamagnetic, and these are the magnetic properties are important. So the non-magnetic property of the titanium is also one plays important role in, not just in our implantology, because if you remember the Dr. Brenmark is who has we accept him as a father of the implantology. He is basically a orthopedic surgeon. Even they use this titanium as bone plates or even various other kinds of implants. So that titanium has its role in implantology or in some kind of prosthetic options in the body. Low specific gravity, that is very important. High specific strength. These are the various favorable factors towards the titanium. But is it enough, or it is the maximum thing what we are using in implantology? Is no, because there is a lot of studies going on, a lot of scientific research is going on, even other materials. Zirconium is picking up very fast, and nowadays even polymers or even bioactive materials. So some people were thinking about the material which can be incorporated to body or totally combines with the body, or not. It cannot be a different structure like a metal what we are placing in the bone, but the research is going on here very thoroughly. So this is literature search from 2008 article. This is basically very old compared to now, but at that point of time, there was a huge research article or a review article which is I've selected for this, because they said the zirconia dental implants, a systematic review it is. So they said that zirconium implants have the potential to become the alternative to titanium implants, but cannot currently be recommended. Currently, you may mind it, but this is a 2008 article. Currently recommended for the routine clinical use. So, but in future it may happen. That is what is there mentioned. But when we talk about the zirconium implants, nowadays we are available. We are doing with the zirconium implants, and we are doing some kind of rock solid implants. There are a lot of pros and cons for that. So they have modified the structure. They have added some more things, and now we are getting ceramic implants and everything. So everything has its own advantages and disadvantages. So based on the structure of the implant, based on the bone biology, we have to select the implant. So again, one more important thing is the procedure. Once you understand the mechanics of the implant, once you understand the biology of the implant, bone and everything, then how to prepare the osteotomy. That is again adds one more advantage. I'm mentioning all these aspects into the this presentation because whenever we do some kind of osteotomy or whenever we can place the implants, every implant or every structure, the company itself, they mention that this is the protocol for our placing our implants. Unless until we follow the protocol thoroughly, we cannot achieve the 100% success rate what we have to achieve through the implant. The present of temperature of irrigation. When I started my implant practice, my friend suggested that you use the saline which is added to our physio dispenser. You have to use it, place it in the refrigerator for some time, so that it is more acts as more efficient coolant than the regular saline. So simple techniques, but it can help it to reduce the uh, and what is the flow of the saline should be there. These are all the parameters given very much in the literature, and even the companies will give a lot of guidelines in this. And what is the amount of bone what we are doing? Some implants, they say compressed implants. We have to do active implants has to be less done little bit lesser osteotomy, and passive implants or the other implants has to be doing then more osteotomy. Drill sharpness and the design. There is limited time to use that particular drill. Number of drills, after some time drills, you cannot use the same drill to achieve the best osseointegration. What is the time you have to use? How much time you have to do the drill? These are all the things important. And what is the RPM? Some implants I've seen, they said only 50 is the RPM what you have to use to achieve maximum osseointegration. So what is the variation thickness of the bone and everything? So whenever we finish the osteotomy, what happens is any trauma, this is the same thing what is going to happen. That is the blood between the fixture and the bone. That is a common thing. I've shown you the images that the blood clot will form between the fixture, what we call as implant. Then again it becomes clot. Then polymorphonuclear leukocytes, phagocytosis come into the picture. Callus forms, remodeling happens, again bone forms. That is how the bone is going to develop around the implant. And next, the osseointegration, what we are talking about is the direct bone implant interface occurs when an implant is allowed to heal in bone undisturbed. This undisturbed is again a major part. So again, there is a controversial discussion about this undisturbed part, because whenever we talk about the immediate loading, that may be functional, that may be non-functional loading, still there can be some kind of disturbance in the structure of the implant. But they say that sometimes the mobility of the implant or micro mobility of the implant will also help in improving the stability of the implant. The main factors affecting the temperature and the implant oxide layer contamination. A distance osteogenesis, whenever we place the implant in extraction sockets, we think about distant osteogenesis. Contact osteogenesis, whenever we do the osteotomy in the thorough bone, then place the implant. Again, the distance between the threads of the implant, the depth of the threads, everything is going to help us in the osseointegration. So wherever we place the implant, the different theories propose different what we call formation of the bone or the repair of the bone or the remodeling of the bone. So it's first 10 days they give some kind of plasma protein aggregation, platelet aggregation, cytokine release and everything. Sometimes say proliferative phase, maturation phase. After this maturation phase, anybody will say that we have to go for the placement of the implant. Another theory says that this proliferative phase is around 2 to 42 days. Maturation is after 21 days. Again, it depends on the bone, it depends on the various conditions what we take up. Thus, the mechanism of osseointegration can be subdivided into osteoconduction, new bone formation, bone remodeling. What are the stages of osseointegration? It's a surface modeling, remodeling, maturation, and everything. I'm going to show some histological pictures after 2 hours what happens. I'm not going to explain all these things because it is more into the histology than the practicality, and I think we are more of practitioners. than the researching in this particular time. So I'll not explain about these slides, but I want to show these pictures because people have done good amount of research on this and they have established these images. After 4 weeks of implantation, they said good amount of bone forms, and after 4 months of implantation, probably you can load it. When we are talking about the immobility of the implant, or when we are talking about the implant success rate, these are the various modes how we place the implant. That is submerged implant, non-submerged implant, and immediate functional loading, immediate non-functional loading. These are the two important things, because whether we can do functional loading or not functional loading, again, various parameters of each implant. Early loading, final crowns within 3 weeks. That is what is early loading. There are a lot of studies which has been done in published in various articles, and of course even the systematic reviews or meta-analysis have done for these articles. So they have seen that immediate loading, early loading, and conventional loading, these are the three terms they use it generally. In these three terms, whenever everything is placed properly, we assume that the implant is placed properly according to the protocols of that particular implant company, or according to the protocols of particular implant field. So the immediate loading, early loading, and conventional loading, they say that the marginal bone loss, there is not much difference in the marginal bone loss, and they can compare with each and everything, even the conventional loading, early loading, and immediate loading. But when it comes to the long-term stability or long-term success of the implant, they say that early loading and immediate loading has no difference, but they are much lesser than the conventional loading. What is the reason behind that? Again, I'll try to explain that coming slides. So whenever you give some kind of injury to the bone, what the osteotomy, what we are doing is nothing but we are injuring the bone. The reestablishment blood supply will be there. The inflammatory process, the inflammation, whenever there is some kind of injury to the bone, the inflammation will start. And whenever there is excessive motion, once you place the implant, the avascular tissue, cartilage, probably this is the failure. This is the Ferguson model, which is very famous and acceptable worldwide. And whenever there is stable fixation, the vascular bone is more formation. Vascular bone is healthy bone, what we call, because the vascularity is wherever there is vascularity, the health will is good for anything. The primary stability and immediate secondary stability is again the concept very much behind the osseointegration. Primary stability when we place the implant, secondary stability when the new bone, remodeled bone forms. And it is advised by many senior implantologists or many people, many companies, that if you want to load the implant, because even the immediate loading implants also, if they are, even if they are doing non-functional loading, they advise to load it within 72 hours or even less than that, because the primary stability is very high, and after that the micro movements may help in improvisation of the osseointegration. But the secondary stability until 3 weeks, it is much lesser. Only if many people say that around between 2 to 4 weeks, better not to touch the implant or not to load the implant between 2 to 3 weeks or 2 to 4 weeks, because the primary stability will be decreased because of the injury whatever we have given, or the pressure because of the implant, the bone resorption will take place there, and the secondary bone is not yet formed. So that is the reason probably they don't advise, don't place any kind of function or any kind of stress on the implant in between around 2 to 3 weeks or 4 weeks. So the immediate loading. So what we think is, it is definitely non-submerged, one stage healing. Second surgery is definitely avoided here. Loads of the implant with a provisional restoration at the same appointment or shortly thereafter. That is probably within 1 or 2 days or 2-3 days maximum. The rationale behind this is reduces the risk of fibrous tissue formation because of the micro movements. I've explained it better. Minimizes woven bone formation. We need lamellar bone, not the woven bone. Promotes lamellar bone maturation to sustain the occlusal load. And it enhances bone remodeling. That is what I was talking about. It increases bone density. I remind you that everything is taken from the literature. Everything is properly explained with the thorough kind of histological evidences. And this is the effect of immediate functional loading on osseointegration of the implant used for single tooth replacement immune histological study. This is article in 2015. Here the conclusion is suggested that immediate loading of implant does not influence the osseointegration process they mentioned here, whereas the density of newly formed peri-implant bone at such sites appear to be increased in relation to the unloaded control patients. So submerged or unloaded implants has lesser density of the bone compared to the immediate loading. So the density is more. This is what they claim. Again, the research is clinical efficiency of early loading versus conventional loading. Here they say that clinical efficacy of conventional loading of implants is much more better, because we have support for everything. But only thing is, what we need to understand is, it is debatable always. The conundrum is again debatable. We have to think before selecting the implant, before selecting the implant planning, there is a saying in everywhere, not just in implantology, that uh, planning to fail is failing to plan. So we have to plan before starting. What is the kind of the bone we have? What is the structure of the bone we have? What is the density of the bone we have? How much cortical bone we have? How much cancellous bone we have? Based on that, probably we need to understand the and what is the necessities of the patient. What are they expecting from us? So all these things we need to understand to select the implant, which is we are doing. So osteofixation is the concept behind the immediate loading of implants. Primary, stable, and cortical anchorage of retention areas, endogenous areas. This fixation is the basic concept which is coming in terms of the immediate loading implant. The stability is achieved either through compression or spongious bone. This is one more thing is importantly discussed in these areas, because even if we are doing the implants into the spongious bone, that is cancerous bone, we need to compress the bone in between the implant threads and get the very good primary stability. And the bone that is autogenous, or the bone bone of the same individual will be there in between the threads, and this will going to give you the mechanical increased mechanical anchorage. That is macromechanical anchorage of the cortical bone. Corticulation, localized increase in the density through condensation of spongious bone. This is procedure. It may be carried out with osteotomes or compression screw implants. So the opportunity is basal implants of a unique opportunity for the implantologist to treat cases which cannot be treated with the conventional implant system. So the conventional implants are very good, definitely, but some cases we will not be able to place a conventional implant because of various other parameters. Reduced bone, or there is no bone where we can place the implant, and the patient is in some kind of immediate necessity of the implants. And when you don't have a proper bone, because placing smaller implants in a cancerous bone, or when the bone thickness is reduced thickness of the bone is there, you may not be able to the conventional. There are limitations of conventional implants. In such kind of cases, definitely the basal implants is going to be helpful. What is the future of this basal implant? How many years are we going to the regular term which is being asked by the patients is what is the guarantee for this? Because for the basal implants, we may not be able to talk about it. And one more disadvantage of basal implants is whenever we try to give some kind of torque, many companies advise that you have to give the torque around 100 or even more than that. So that torque, at the time of giving that torque, some people have seen a cases where they use high torque. They try to use the high torque with an implant which is around 2.5 or 3 millimeters of implant, and the implant fractures. The fracture of fixtures while doing the torque has acted. And this is a thing which we should avoid it. So we need to understand the bone availability of the bone, and we need to understand the structure of the implant, then place the implant. And this basal implant again called as cortical implantology, because always we need to place the implant into the cortical bone. The high density and this Salama et al. Criteria for this thing is the high density of the bone is very much important for the implant side. If you think of the conventional implants, they say that more than D1 bone, the D2 or D3 bone is more suitable for placing implants. But here the D1 bone is more suitable for the placing the implant. When there is more D1 bone, probably you may have to think about the conventional implant. The implant design that increases the mechanical retention. So many companies claim that smooth implant will not give any adherence to the plaque and other things, can give success rate of the implant. But rough surface of the implant will give increased primary stability. You have to understand this concept and select an implant. The bicortical implants, this is we need to attach the implant to the adjacent bilateral cortical plate to increase the stability. And a reduction of distal cantilevers, that is very important. Protector occlusal scheme, the prosthetic part plays a major role in single piece implants or the immediate loading implant, because in a conventional loading implants you have various designs of abutments, and you have various things where you can plan a prosthetic part comfortably. Prosthetic options are very huge in conventional implant, but in immediate loading implant we have little bit reduced. Of course, nowadays even they have come up with various other options, but still the prosthetic part is much more difficult in immediate loading implant. But I personally feel that implant is prosthetically driven, because the patient comes to us for the teeth, not for the implants. So we have to give them the functional teeth, which is the prosthetic part of the implant, which is very important. So if implant failure occurs, we have to keep it in mind that the patient may become a dental cripple. He will not be able to go for any other better prosthetics again after that. So whenever we are placing the implants, we need to select everything and then go for the placement of the implant. Therefore, autogenous bone grafts upgrade the bone. So I asked you a question initially that whether we should augment the bone initially, then go for the implant, or both at the same time. Personal things or my personal opinion, or in the literature it has given that graft it first, then probably go for the implantology. But in some cases, the patient is not suitable for the graft, or not willing for the graft, or various other limitations may restrict this practice. for going for the graft, but placing the implants immediately. The autogenous grafts in place allowed for 5 or more months. The endosteal support implants may be inserted. So next thing is, I would like to a few more questions. This clinical picture, can this implant restore because of the lot of bone loss and everything? Then the answer is again no for this. And will this osseointegration improve? Can we wait for more time? Again, the answer is no. Once it is failure or once there is a bone loss after placing the implant, if you observe it after 2-3 months of your post-implant placement, then you need to understand that you need to replace the implant or you need to think of the other alternatives. So again, when we think about the prosthetic part of the implant, again, we need to think about the structure of the implant, the periphery of the implant where it is placed. So we need to comparison. There should be some comparison between the tooth and implant, what we are giving the process. When we are giving a simple crown, what are the things to be considered? Given the implant, what are the things to consider? So the epithelium, the connective tissue, the biological window, the junctional epithelium, everything comes into the picture here. So the fixture of the implant site does not have a periodontal ligament, but has nerve endings located near the fixture, sensing pain and temperature. Yes, this is true. Again, proven by the literature is it is located near the fixture. The nerve endings will be there in the bone, but may not be the periodontal ligament. They may not have the proper tactile sensitivity or these things. The patients with osseointegrated implants have high threshold and low sensitivity. I'll explain you what exactly this is. High threshold and low sensitivity they have. The tactile function of the teeth is it can detect even 20 microns thickness of the food or the whatever we keep it in the oral cavity. And 1 to 2 grams of weight also on the tooth will detect the tooth, because the tooth is not a skin or some other thing. It's a very hard structure. The proprioception of the periodontal ligament has to give us the feeling of whatever we are eating or whatever is touching to the tooth. And after placing the implants, the thresholds are increased levels up to 50 to 100 microns. So this increasing the threshold means only thing is the 50 to 100 micron thickness of the food only can be felt by the implant because of the lack of periodontal ligament, and only 50 to 100 grams of upon loading is can be detected by the implant. Simple things or lightweight things are 1 to 2 grams may not be detected, and sometimes it can be harmful because unless until there is some kind of trauma with this kind of heavy food or everything, then you cannot say that it is able to detect. So this more thickness or more traumatic things what we do with our teeth can result in the failure of the implant because of the we need to plan it properly. Whenever we are giving it's a full mouth implantology is different, but even single implant or 2 implants when we're giving, so we need to consider it regarding with the adjacent teeth where the height of the implant, because whenever we chew with the teeth, the slight mild compression with the natural tooth will be there, probably around 20 microns or less than that. But when the implant, the compression will not be there. So you need to place the implant crown a little bit less. This is the accepted fact by every implantologist that the implant crown should be slightly lesser than in height compared to the natural tooth. So that is the reason, because the compression will be there, the load will be reduced on the implant. It should be in good function, but the load should be reduced. And as the periodontal ligament is missing, the fixture remains reduced amount of receptors will be there, right? And there are various methods to assess osseointegration, and maybe we may not use all those things. Only thing we use is TARC, or we go for the regular X-rays, IOPs, or some other X-rays to measure the stability, or these Osteo or bone test things we have. Only based on that we need to check the implant stability, probably then go for the prosthesis. Again, whenever we are loading the implants, all just 3 or 4 implants are used to support the fixed process. So we do some kind of cases whenever we are doing some kind of, because a lot of NRAs they come to us and they want implants under teeth in within no time. In many cases, we'll not be able to place the immediate implants because of various reasons. And my personal feeling about the immediate implants is you need to have very good surgical skills to place the implants into the deep into the bone, zygomatic area, in the cortical areas, or near to the nerve, or bypassing the nerve and everything. You need to have a lot of surgical skills. And if anything goes wrong, probably I told you that the patient may become dental cripple, and we will not be able to handle that case immediately. And all NRIs, as we know, that they are in a hurry to get it done faster and everything. In such cases, what I prefer to do is replace the conventional implants initially, and then give some more 3 or 4 or some immediate loading implants, and give a temporary process on that. After 6 months or 1 year or whenever they come back, if these temporary implants or if these immediate implants are good enough, we can use it as a permanent implants. Or if they are in failure stage or if there's some other thing, then you'll remove it and go with the permanent prosthetics with functional conventional implants. This is generally used in totally edentulous. Otherwise, we will not have will not be in a situation to have this. And once you understand all these things, you can comfortably go ahead with the implants. That is, the success rate in the literature given is the tooth supported bridge has only 74% success rate. A lot of failures because of various reasons. The margins are not proper. Even if they are done properly, the maintenance part and everything. But the single tooth implants has 97% of success rate. Even the other things also has fairly more increased rate of success compared to the our conventional implant, our regular process. So I'm coming to the last slide of my presentation. That is, whenever we talk about the implants, these are the factors, key factors that is responsible for the success of osseointegration. Because I'm repeatedly insisting on the word osseointegration, even though we are using immediate loading implants, because even the immediate implants will show the osseointegration. It is the term, whatever you define it as, however you take the structure of the bone, the term is what we use osseointegration. But only thing is, various the loading conditions, surgical considerations, state of the implantation, host bed, the implant surface characteristic, implant design characteristic, and implant material biocompatibility. All these factors you need to understand and consider before placing the implant itself or at the time of planning. After that, you can think of placing the implant. With this, I end my presentation and
All right, move to the first question. What is the success rate of basal implants?
yeah, the success rate, unfortunately, in medical or dentistry everywhere, they say it's we have only 5 years success rate. Literature we are available with that. So, but whenever we go through the material, because I don't say that the success is very good, because whenever we think about the or talk about the success rate, first thing is it's only 5 years we are talking about. They don't have that literature backup for the long literature as we have with the conventional implants. But initially, because I personally have done good amount of basal implants or cortical implants, but in my experience, the success rate is compared to other implants. I don't say that I don't have any failures in those conventional implants, but the success rate in these implants is low because of various techniques we follow. Because we try to give this basal implants whenever it is not possible to go for the conventional implant. Many dentists or some dentists, I should not use this word on this platform, but the of commercialization is also helping this improvised basal implants. So whenever you select a basal implant, because in the particularly lower anterior teeth or in kind of some zygomatic implants and everything, the success is pretty high. But in total, if you consider the implants placed in the maxillary, wherever the implant is not properly placed or those things, then the success rate is not very good, because the surgical technique and the placement and the case selection is very important, what I feel personally, in the success rate of this. If you select the case properly, then definitely the success rate will be very high.
Thank you so much, sir. We move to the next question. Once again, it's a question related to basal implants. If basal implants can be given as an immediate solution and immediate loading implantology, then why is the world still doing conventional implantology? Don't you think conventional implantology is time consuming? And if it's time consuming, why is doctors still not convinced about basal implantology?
Yeah, I told you, no, because the basal implantology, the limitations are, I feel that much more higher than the conventional implant, because conventional implant definitely we have limitations. In basal implantology, the placement of implant is definitely, it should be bicortical, I feel. The compression implants, what they say, and a simple statement what they have given is there is no bonding, only adhesion. But the bonding is equally proven in histologically. And one more thing is, the conventional, the basal implants, we give it immediate loading, but immediate functional loading gives better result only when you place the implant properly and when the process is very high, very highly accurate. And whenever you are not going to give that process, because I've touched the tactile sensitivity of the implant and everything, because the only reason is you need to understand that the prosthetic part plays a major role, and the prosthetic process is definitely compromised. Of course, they are coming up with good solutions right now, but still it is compromised compared to the conventional implants. And the literature support what we have for the conventional implant, because why I prefer conventional implants over basal implants, whenever the patient is comfortable or whenever I am comfortable or whenever I can convince the patient with the conventional implant, the only reason is I have very good literature backup and very good scientific backup for the conventional implants, which is unfortunately lacking for the basal implants because they are new. And of course, the advantage of basal implants are not ruling out them, but the only disadvantage is the surgical technique should be very good. And if you are unable, because I have seen some cases in various places where I have rejected doing the case because of the patient is cannot be comfortable with the implants. Many basal implantologists, they have done the cases, and because of some other factors they got failed. So the failure chances, what I feel, is more high because of various limitations of the individuals, the practitioners, or the bone conditions. And so that is the reason probably the world is still going with the conventional implants. And even today the conventional implants come out with a lot of other options. That is, wherever there was initially there was a screw loosening was there, but right now because of the conical connections and self locking of some implants, for example K3 or these implants, they said that this screw loosening and these things are gone. And even the conventional implants, they are very active. Sometimes the immediate loading with the conventional is also being accepted. So the research is going in both ways. So probably there is no harm in selecting any implant, but it should be based on your skills and of course the condition in the bone.
Thank you, sir. What would next question be? Next question is as follows. What would be your ultimate solution to medically compromised patients, patients with diabetes, patients with osteoporosis? What kind of implants would you prefer and why?
Yeah, but if the patient is diabetic and if the sugar levels are in control, he is a normal person for me. I don't consider him as medically compromised because if he can control his, and generally we go for any kind of blood investigation, that is HbA1c, these are the blood tests we do. And if it's uncontrolled diabetes, then definitely any implant is going to be a failure if it is a conventional base or whatever it is. And some kind of osteoporosis and everything. Again, you give, because one implant case I've seen, because in my seniors clinic, that the vitamin D, reduced vitamin D levels also considered supported the failure of the implant. We can handle the patient because the medically compromised patient, we can outrightly, we need not reject the case. The only thing is we need to address the medically compromised condition, because some cases where we can, because there is one more concept in the implantology that whenever the patient undergoes that radiation chemotherapy for a cancer and everything, the implant cannot be placed in at least for the 2 years. The radiation oncologists say that 2 years better leave the case without doing anything. But some people say that no, we can place the implant immediately. The cortical implant, cortical bone is not affected. There's nothing like it is not affected. But only thing is when you consider all the factors of the patient, and when you can handle those complications in your clinic, or when you can handle those complications in your with your medication or with your support. But in these cases, I don't prefer immediate loading because they're already some kind of compromised. So better go with the conventional loading. But if time permits, doesn't permit, or if the patient cannot have conventional implant, probably basal implants also okay in that case. But only thing is you need to understand the medical condition, you need to control the medical condition, then probably go with the implant.
Thank you so much, sir. Last question. What kind of effects on osseointegration process in patients with biphosphonate therapy?
Yes, this biphosphonate therapy is definitely a harmful condition because there is possibility of osteomyelitis, because we are going to do some kind of injury. And these patients with this kind of chemotherapy, which is going to affect the bone condition and everything, we can take certain protocols, and we can take the opinion, because they give some kind of prophylactic medication, the oncologist or the physical physician doctors who are treating them. So there is a good amount of medication to support that condition. And but they advise the medication only depending on their side effect, because every medicine has its own side effects, and you cannot say that this medicine is safe or that medicine is safe only by support of that medication. Because I have done good amount of cases, the patient undergone chemotherapy or radiotherapy, we give some kind of medication with the consent of radiation oncologist or chemotherapist, and then we advise the medication for the patient. Well, take all precautions. Of course, we have to take all the precautions, sterilization and everything for every patient, but some kind of addition to the medication for this patient, and we can go ahead. That's absolutely no contraindication as such, but you should understand the condition of the patient, and if, the no contraindication doesn't mean that you can handle in every aspect. You have to take care in every aspect. You have to answer those compromised things in the patient, then go ahead with the implants.